The narrowing aortic valve, which stands at the main gate of the heart, the very point from which the circulation goes out of the heart for the entire body, is reasonably commonly seen, especially in the elderly population. Many of them may not be fit for the conventional open heart surgery. Transcatheter valve replacement, TAVI, has been a very good alternative for people who are not fit to undergo the conventional open heart method of valve replacement.
Transcatheter aortic valve replacement is a minimally invasive intervention procedure for aortic valve replacement without any surgical incision or a major heart operation.
In this procedure, we go through groin arteries and then we take the valve from the groin inside the diseased valve and we deploy the spine. So this is how it is done. And it is done in constant sedation. The patient will be awake, they will be talking, they will be sedated of course, and then this procedure is done. And next day the patient is ambulatory and we can discharge the patient next day or day after that.
The cost of TAVR or transcatheter aortic valve replacement used to be around 30 to 35 lakhs earlier, but progressively it's coming down. Now actually we can do this procedure between 15 to 20 lakhs. It may appear to be expensive, but if you look at those patients' overall complications and morbidity point of view, this treatment is really cost effective because it is a short procedure, hospital stay is only 24 to 48 hours, and there is no general anesthesia, no ventilation, no intubation, and the complication is minimal.
Last case, which you will see the video, this patient went home within 48 hours and he is doing extremely well. He is 82 years old. All our patients are more than 80 years. The previous patient had a good history of two episodes of sympathy, and the first patient had a very bad run with severe obstructions.
I recommend that those patients who are suffering from severe aortic stenosis, aortic valve disease, having chest pain, shortness of breath, or even sudden unconsciousness, should consider a catheter-based aortic valve replacement rather than a surgical aortic valve replacement.
Of valve replacement. We in Medica, in a combined exercise of both the surgical and the cardiological departments, have had a very good.
Very good afternoon. Namaskar. On behalf of Medica Super Speciality Hospitals, we extend a warm welcome to all of you and our dear friends from media and our respected senior clinicians. Today, it's a very momentous occasion. On behalf of Medica, we would like to share with you that we have performed a very rare complex procedure, which is the world's first successful conduction system pacing on a male patient whose heart is positioned on the right side. As Dr. Kumar will eventually share with you the complexities involved in the case and how innovatively the challenges were overcome. On behalf of all of you, I take this opportunity to welcome Dr. Dilip Kumar on the stage to discuss the details of the case, and following which we have our senior clinician, Dr. Professor Ravin Chakravarti sir, here also with us. So sir will also share his expert opinion on how this case, created a milestone in this part of the country. Dr. Kumar, welcome to you.
Good afternoon, everyone. So, let me begin with saying this. The gentleman who is sitting here, he is unaware that something which was done on him was done for the first time in the world. Not in Medica, not in Eastern India, not in India, not in Asia, but across the globe. So he had a unique problem, and we all have heard about organs placed just opposite to the normal position. Someone has a heart in the right side, someone has a spleen which should be normally on the left is in right, liver is in right, but it is in left. So there's some congenital anomalies which we call dextrocardia or situs inversus. But he had a unique problem. So dextrocardia also, a lot of pacemakers have been done. But in his situation, it was a dextroversion. Dextroversion means it was not from his birth, the heart was on right side, but because of his underlying problem in the childhood, he had a damaged lung of right side, and this damaged lungs, the right lung, healed by fibrosis. And because of the fibrotic bands, the entire heart, the mediastinum, the trachea was shifted towards right. I will show you the pictures. And when you do something on right, which we expect in left, we need some newer hardware, some different hardwares, dedicated hardwares, and that too in dextrocardia, normal congenital right-sided heart, we expect something, they should be like this, they should be like something like this. But it was an acquired problem. So with fibrosis, right ventricle was pulled, right atrium was pulled, below something else was pulled. So how the heart was pulled, you never know. So the entire anatomy of the heart was, not very clear to us how these things are happening and which location, which is the normal ventricle, right ventricle is there or not. So let me explain you something about some kind of basic facts about pacing and conduction system pacing. So I hope all of you can appreciate that there are some complexes in the upper one. You see, can you see here this complex? এটা মোটো আছে দেখছেন আপনি, this is a white QRS, can appreciate here. And the lower one, this is a narrow complex. These all are paced complexes. So whatever the upper panel, till the first pacemaker was implanted in world in 1958. Before 1958 there was no pacemaker. So anybody who was having heart block was left over to die. 1958, a gentleman called Mr. Larsen got the first pacemaker, and that lasted for 6 hours. He was given another pacemaker that lasted for 7 days, and in his entire lifetime he required 26 pacemakers in his lifetime, and he outlived his surgeon. So the Dr. Sening performed the first pacemaker, and Mr. Larsen was present in the ceremony, the kind of in his burial and final rites. The Larsen was there, Dr. Sening was dead. So So he outlived his surgeon. So this is a fascinating journey of pacemakers, how it started. And it saves life, you see. A pacemaker, without pacemaker, you are almost dead in coming days. With pacemaker, you are, totally living, doing everything, doing marathon, you can swim, you can do anything. So from 1958 till 2010, all the pacemakers which used to be done, they used to carry this kind of white QRS complexes. You can see here. So it can give your heart this stimulus to beat, but at the same time, it comes at a cost of 10 to 20% chance that patient can develop heart dysfunction. So those who had pacemakers before 2010 or 2015 or even present time, if someone is given normal pacemaker, out of 10, 1 or 2 will have cardiac dysfunction in coming days. And what would happen to these patients? They would come to us and we will go for a CRT implantation or something else, so that his QRS, the widened QRS, should be fixed and should be brought narrow. So this is the basic idea why CSP came into picture. The conduction system pacing, the lower one is conduction system pacing, where the QRS is not wide, QRS is narrow, and the 10 to 20% chance of cardiac dysfunction is not there. So this gentleman who has a heart in right side, suppose you have done a normal pacemaker and he falls in 10 to 20% of case, what will happen next time? Going for a CRT in this kind of anatomy would be almost, you will be surrendering to the patient, no, I can't do anything, you have to live with this compromised heart. And that was the challenge before us. We had to do a CSP in this case because we had no option. We can't put the patient 20% risk of heart dysfunction, and we decided to do CSP unknowingly that this could be the first case in the world. And the CSP happens because we target the conduction system. So you see here, this is the conduction system. We have electricity here, we have electrical lines here. So we directly go and pace the electrical lines. So these are normal physiological pacemaker. The conduction system pacing is also called physiological pacemaker. Just like normal heart pacemaker, which is the sinus node works and AV conduction and normal conduction works, you reach out to this conduction system and pace. So these are some pictures of CSP, which is being done by many methods now, Medtronic, St. Jude, Abbott, Boston, and these are some ECG. And this is how we do it. These are some catheters which we use from pictures from operation theater. It is not his pictures, his case is from different patients. Operation is going on, and these are the ECG findings. And you see here, can you appreciate this lead? This lead goes inside the conduction system. We just screw it. You can see there, and which gives us a ECG, which we see electrically through EMGs during the time of procedure, that ECG is not wide. We look at other parameters, which I don't know, I don't want to tell here. So many things we see, but the idea and goal is to give a narrow QRS complex, normal complex, and then we remove this. And we, as a team here, we have trained almost 40 doctors from across India on this procedure, conduction system pacing. And this gentleman came from probably Assam, Dr. Mayank Agrawal, Dr. Reza from Maharashtra. He is Dr. He's from Calcutta, Dr. Rana, Dr. Shivani. He's Dr. Avades. He's HOD of Kanpur Medical College. He also came and got trained by us in conduction system pacing. So this, institute, Department of Cardiology, and we all as a collective team, it's not me, Dr. Ravin, or anyone else. We as a team gives and imparts training to all the budding cardiologists, experienced cardiologists even, in this field of conduction system pacing. And this was a testimony what Dr. Avades wrote on his LinkedIn. And he highly appreciated how this hospital and institute is giving training to everyone. And these are some cases of heart dysfunction. You see 28% heart function, and the conduction system pacing is done, and the ECG becomes narrow, and he becomes normal in 3 months' time. So this is conduction system pacing. It gives you a normal heart function in a very short span of time if the problem is because of dysynchrony. And you see here the studies. There are so many studies worldwide which have been done, which shows very strongly, undoubtedly, and most emphatically that conduction system pacing is the way to go forward, and it has to be there as replacement of all the normal pacemakers. And I hope more and more doctors from across country, different regions, they would be getting trained, and majority of these people will be trained by us. So these are some difficult cases which we have done earlier. Now I will not waste time, and I will talk about Mr. Rezaul. And he is sitting here and he is happy. And he had some problem also. I will be showing his, and he will also tell his experience. So let me go to his case. So this lady had a scoliosis of spine, and we could do a conduction system pacing. It was published in journal. Again, we have done some research on conduction system pacing on different population set, and it was also published. So we are a center which has published many studies on conduction system pacing. So and that is why we could afford to take this challenge, to give this gentleman a narrow QRS which will not put him in danger of a cardiac dysfunction. So this is the CT scan of Mr. Huck. You can see here, the heart usually comes here, left side. I request everyone from media to pay attention here. This CT scan, this is the left side, this is the right side. And you can see here, the left side, usually you see a heart here, and it just this kind of lungs here, the entire left part. But you can see there is hardly any, lung tissue left here. It's all fibrotic bands, non-functional right side of the, lung. And it is all fibrotic bands which pull the heart from right to left, left to right. And when we did the venogram, you can see here, the vein is coming from left to right and draining. And this is the final position. So I will tell you the challenges of what all challenges which we had. So this patient, he had a heart here. So the catheter has a limited length. So we can't go from here because your catheter will be exhausted here only. You will not reach the heart. Normally it will go and reach the heart. The catheter length is same. So how can you expect that you puncture here and you will reach there? So we punctured here, very medially, so that our catheter will reach here. And then we were not sure where is right ventricle, where is the right atrium. So we took the right atrial lead, which lead should be going into right ventricle. We took into right atrium, right ventricle, and we paced and we saw that, okay, right ventricle is pacing, and that gave us an idea, oh, this is right ventricle and this is tricuspid valve. And then we negotiated our catheter through this tricuspid valve, which we can see through the right atrial, lead, which was the right ventricle with its loop. With its loop, we can make out. And then we negotiated our, sheet there. And then we went inside and we electrically mapped the entire right ventricle septum. And we found a place where we can see that the QRS could be even narrower. And what we call in medical term in LVAT, left ventricle activation time, lateral valve of the ventricle, and we found that it is well in the normal limits. And this is the picture of the X-ray which was done next day. And you can see this is the left side, entire left side lung. This is hyperinflated because it has to work extra to compensate the right side lung also. So left side lung is so hyperinflated, you can see here, and you can't make out a cardiac shadow. This is the cardiac shadow. So this is the cardiac shadow.
Yeah, you can take the arrow in the laptop. No? Arrow in the laptop.
It's not working.
Oh.
So, and two leads you can see here and how it has come. And this was the ECG. So we can definitely tell now that Mr. Rezaul will not develop cardiac dysfunction because of the pacemaker, which happens in 20% of patients. So we all feel that once pacemaker is put, we are, many patients feel that they are now become, immortal. Nothing can happen to him. they can't be having even cancer, they can't be even having lungs problems. So it's not like that. From heart side, the conduction system side, the electrical stimulus they will be getting, but they will not develop this heart dysfunction because of conduction system, and that is what we have done. And we reviewed the literature. No one has done it yet. So you will ask me why no one has done it yet? Because this is a new technology which has come in last 15 years, conduction system pacing. And we got Mr. Razaul, we took the challenge to do it because we are a training center for conduction system pacing. Not only in India, from Asian countries, people come, doctors come to us and we train them. So that's why we could do it. And that is Mr. Karim, what he told to us. I will, and then he is there before all of us.
আসার পরে দিলীপ স্যার আমাকে বললো পরীক্ষা নিরীক্ষা করার পরে এসিসি করার পরে বললো তোমাকে হার্টের মেশিন বসাইতে হবে। আমি হার্টের মেশিন বসাতাম, বসিয়ে আমি এখন এই মাঝে মাঝে সেন্সলেস হয়ে যেতাম। হার্টের মেশিন বসানোর আগে ওই নামাজ পড়তে গেলে অসময় জ্ঞান আর হয়ে যেতাম, নিজে যখন সিজা যেতাম। তখন এবার স্যারের কাছে আসলাম, স্যার এবার দেখে বললো পেসমেকার বসাতে হবে। পেসমেকার বসিয়েছি, কিন্তু ওই যে নিচে হলেই যে জিনিসটা হচ্ছিল সেটা এখন হচ্ছে না, সেটা এখন ভালোভাবে দেখছি।
So we will have more discussion with him and his family members. And now I invite Dr. Naveen Chakravarti. He is our mentor, teacher, and senior vice chairman. I request Dr. Rana Rathore, Dr. Subrasekhar Chakravarti, Dr. Anand Pandey to come on stage and share their experience, because they all were there with me when we were operating on him. So it was not a one man, one person's job. It's the entire team which gives their effort.
You can switch off. You can switch off this. You don't need.
Lights will on.
This one you can switch off.
I request first Dr. Chakravarti to give his kind of briefing on exactly what is CSP and what we have done as a team, carries the what it means for the world and for the CSP.
I think this is for all of you, especially people from media, to understand that the uniqueness of this case, it is, we know that dextrocardia means that when the heart is on the left side, on the right side, normally on the left side is the right side. Dextrocardia.
Can we have one more chair for the patient as well?
Dextrocardia, right-sided heart, it can be with when the entire organ has been moved. For example, liver is on the left side, stomach is on the right side. That is called situs inversus. Means that the entire thing on the other side. But sometimes you can have only heart on the right side, other organs are as usual. Liver is on the right side, stomach is on the left side. It's called situs inversus, situs solitus with dextrocardia. Now, the uniqueness of this case is the heart has been moved out from its normal position to the right side because the right lung is collapsed. The size was small, so it has been pulled. It has pulled the heart to the right side. This is called dextroversion. It's pulled. So because of that, the anatomy got completely distorted. Hearted যেটা anatomy, সেটা পুরোটা পাল্টে গেল. So when you access that, it is not that easy. This is one. The other challenge is, which everybody should understand, since the right lung is not functioning, it is small, the left lung has to function more. So left lung has to function more. So left lung is hyperinflated, a lot of air. So when you do the procedure from the left side, you can actually puncture the lung. Because, normally we go outside the lung and then puncture. But since the whole heart has moved to the right side, you have to be very close to the chest wall and then puncture. While puncturing with the needle and doing the operation, you can actually cause injury of the left lung. And if you cause injury of the left, it's gone because the right lung is not working. If you injure the left lung, it's finished.
That is something which is extremely difficult, and it is not so uncommon to puncture the lung while doing the procedure. That can cause pneumothorax, even the collapse of the left lung. And if normally if it collapses, the right lung takes over. His right lung is already gone. That is a big challenge to do such case, that when the only one lung is functioning. That is another challenge. And then of course the understanding that kothai right ventricle, kothai left, where is the position is not that easy. You have to have orientation, because normally we are oriented, heart is on the left side, so the right ventricle where the lead goes is on the right side, but here is completely disturbed. So it is not that easy to orient yourself that to position the lead. That is one. Secondly, the conduction system pacing, CSP, means that you put the lead, the right ventricular lead, not all the lead, right ventricular lead, in the main part of the conduction system. The conduction system means the electrical circuit of the heart. You have to screw the lead on the main part of the electrical circuit of the heart. Normally we put on the left bundle area. That we have done a publication. And in fact, one of our postgraduate fellows did a research on that. And now he is of course our associate. So this is a unique paper that has been published, probably the only publication. And we have done literature on that. We have published in review journals. It's a very fascinating work that we have done. So to do that conduction system pacing in such a abnormal located heart, in a patient where right lung is not functioning, you can understand the complexity of the case. And then after that patient is doing very well. By doing so, one is a great kind of job by the cardiologist and the entire team. Secondly, it's a great relief for the patient. So because he will not get any cardiomyopathy, because normally আমরা যখন পেসমেকার লাগাই আমরা রাইট ভেন্ট্রিকলে লাগাই, রাইট ভেন্ট্রিকল লাগালে সেই পেশেন্টের 20 to 25%, 1/4 পেশেন্ট হার্টের ফাংশন খারাপ হয়ে যায়, তাই না? তো সেক্ষেত্রে এটা হচ্ছে না, তো পেশেন্টের লাইফটা বেড়ে যাচ্ছে. So that is one. And then he himself said that when I am just going down and doing some work, I feel dizzy because heart is slow. Now heart is functioning normally. So these are the incredible work done by Dr. Dilip Kumar and the entire cardiology team. And we must give a big hand to him and to everybody. It's a great thing. So, and if you say that Dextrocardia with the pacemaker, that has been done. Even in India, we have done here also. India, the first paper was published sometimes in 2014 from Bangalore. But later on, many pacemakers were done. This such kind of pacemaker implantation has not been reported in the literature anywhere. I did not come across such kind of issue, which is unique. So that is what is the uniqueness of the case, and it's good to see that patient is doing very well.
We can have quick comments from my colleagues who were there with me, Anand, Subrasekhar and Dr. Rana, who were there with me during surgery. And also Ashish was there. Ashish is not, we are missing him today. He has got some work. So Anand, quickly, or Rana, can you start quickly? One or two words.
Yeah, it was really a challenging case. You see, because one lung was already damaged, and the only functioning lung was another lung. And second, that you can put pacemaker. Normal pacemaker is not an issue, but putting this kind of pacing, which is a new technology, you don't have to that kind of exercise in that kind of situation. So it was really a challenging case. And because we have to think that there should not be any complication, there should not be any kind of cardiac dysfunction in the future. These were the things that should we have to keep in mind. And in all this, I think really it was done successfully, and the patient is sitting here. So it's really grateful to all of us, and a kind of achievement for the institute as well as the cardiology department. Thank you.
Anand, your experience when we took the patient, both were there, and they were they made me hesitant. Dr. Kumar, this is on right side. How will we performing CSP? Let's do a normal pacemaker. Then we discussed amongst ourselves. No, this is how we will do it. Our senior technique, cath lab in charge, Arnav is also there. So we had a plan. We just sat like we are going on a war. Like we are going on a war with some country, something like that. We sat for 10-15 minutes. No, now this is this kind of part. We did the echo. We asked for their reports, previous reports. We planned, and then so Anand, can you tell me?
We did HRCT, and at the same time, while doing the procedures, we did check for this liver, where is the where it is present. Naturally, it is present on the right side. To know the anatomy of this heart, whether it's a dextrocardia really or acquired dextrocardia. And again, we were getting a lot of problem while placing the ventricle leads. and seeing the VPC, we located the ventricle, and after doing that, placing the ventricle lead, we were not getting the proper position for atrial lead. So it was a very difficult, and it was an amazing experience what I got, and I'm thankful to be a part of this procedure, I will say.
At the outset, I would like to thank you, sir, for allowing me to share the stage with you, and also sir. And it was a great experience and a huge learning experience for me to be able to learn what I have learned about CSP, and especially this case, which is technically challenging and helped me learn a lot from you, sir. And I am still learning so much. It's a very difficult thing to understand.
We had this idea that we are dealing with situs inversus. Everything is on, opposite side. So heart should be on right, so liver should be on left, something like that. But once we saw the ECG, Subro brought the ECG. No, this is one AVL is positive, so it can't be situs inversus. So someone brought echo machine. Then we saw no, liver is on right. The Anand saw no, this is liver is on right. And then we had a kind of discussion for 10-15 minutes. Totally, we brainstormed what we need to do. This is not a normal situs inversus, not normal dextrocardia. So he had a kind of acquired kind of problem where heart pulled. And once the heart is pulled by fibrosis, you really don't know which chamber was pulled, which side.
Pulled like that. It should be rotated.
Totally unimaginable. And that created the main problem, and that's why we had to struggle for 20-25 minutes. But touch wood, because of and I have seen patients will. If a patient is willing, patient is supportive, big things can be done very easily. So he was all along very supportive, and always encouraged, bhalo achi. So and procedure went well. And then I can now request Mr. Rajaul and his family members to just tell us some experience if they wish. Bolun, ইচ্ছা করে বলুন, and then we can open it for question and answer. বাংলায় বলুন, বাংলা।
এখানে যারা আসছেন ডাক্তারবাবুদের এবং যারা আমার সামনে বসে আছেন প্রত্যেকটা আমি আন্তরিক ধন্যবাদ জানিয়ে দু একটা কথা বলছি। আমার ডক্টর দেবাশিস চ্যাটার্জি এখানে পাঠিয়েছিলেন স্যারের কাছে, দিলীপ কুমারের কাছে। স্যার আমি এসেছিলাম, এসে স্যার একটা ডেট দিয়েছিল, সেই ডেটই আমি এসেছিলাম। এসে সেই দিনকে আমাকে অপারেশন করেছিল, মানে হাড়ে মেশিন বসিয়ে তারপর দিনই ছুটি দিয়েছিল। যাই হোক, আমি মেশিনে বসানোর পরে আগে যে কষ্টটা আমার ছিল, দমের কষ্টটা এখন একটু কম আছে। আমার সমস্যা, আমি ছোটবেলা থেকেই সমস্যায় জড়িত ছিলাম। আমার একটা লাংস খারাপ ছিল, তো যেটা আমি পরে শুনলাম ডাক্তার ওর কাছ থেকে, যেটা ছোট কিডনি জাতীয় জিনিস লাংসটা খেয়ে ফেলেছি। যাই হোক, আমি বিভিন্ন জায়গায় প্রচুর ট্রিটমেন্ট হয়েছি বা খরচও করেছি, কোনো জায়গায় সুরা হয়নি। তারপরে সুরা না হওয়ার পরে অনেকেই ডাক্তার টিভির ওষুধ খাইয়েছিল। তারপরে আমি ভেলোরে গিয়েছিলাম, আমার হাঁটার ক্ষমতা ছিল না, প্লেনে গিয়েছিলাম। প্লেনে গিয়ে ওনারা সমস্ত কিছু পরীক্ষা নিরীক্ষা করে বললো টিভির ওষুধ খেয়ে দিয়েছিল, আমাদের ওখানে ডাক্তার দিয়েছিল, বললে এখন খাবে ওষুধের খাবে না, ও খাওয়ার দরকার নেই। তারপরে বন্ধ করে দিলাম। তারপর আস্তে আস্তে আমি আসি, ডাক্তারকে দেখাই, কিন্তু বিভিন্ন ওষুধ দেয়। কিন্তু এদিনকে আমি অপারেশন করার পরে যেটা দেখলাম, আগে যে আমার কষ্টটা খুব বেশি হতো সেটা আস্তে এখন একটু কম আছে। আর আমার যে ইদানিংকালে যে সমস্যা হয়েছিল, সেটা আমি নামাজ, তো আমাদের ইসলাম শরিয়াতের মধ্যে নামাজ পড়তে হয়তো 5 ওয়াক্ত, ওই প্রায় ওক্তে গিয়ে নামাজ যখন পড়তাম, তখন আমি যখন সিজদায় যেতাম নিচে হওয়ার সময়, তখন আমি সেন্সলেস হয়ে যেতাম, আমার কোনো জ্ঞান থাকতো না, আমি অজ্ঞান হয়ে পড়তাম। সঙ্গে সঙ্গে কিছু জানি না, জানতাম না। আমার ছেলে নেই, 3টি মেয়ে। যাই হোক, খুব আমার নিকটস্থ, ছেলের চেয়েও মনে হয় নিকটস্থ থাকে, ফোন করার সঙ্গে চলে আসে, ও হসপিটালে নিয়ে যায়। হসপিটাল নিয়ে গিয়েছিল বহরতলা, আমাদের এখন বসিরহাট বহরতলা। 3বার হয়েছিল, তারপরে 4বার হয়েছিল। তারপর ডাক্তার কাছে আসলাম, ডাক্তার বললো তোমার হার্টের ডিস্টার্ব, ও তুমি এক্ষুনি হার্ট ডিপার্টমেন্ট নিয়ে যাবে। তো উনি পাঠানোর পরে আমি এখন যেটা দেখছি যে আগে যে দমের কষ্টটা খুব হতো, কথা বলতে গেলে হাঁটতে গেলে, এখন একটু কম আছে। আমি ডাক্তারবাবুদের সবাইকে আমি আন্তরিক ধন্যবাদ জানিয়ে আমি আমার সংক্ষিপ্ত বক্তব্য শেষ করছি। করার আগে একটা কথা বলি একটু, যে আমি আমার ফ্যামিলি যদি কোনোদিন অসুবিধা বোধ হয়, তা আপনাদের এখানে কোনো সিস্টেম আছে কি? একটা আমার স্বাস্থ্যসাথী কার্ড আছে, সেই স্বাস্থ্যসাথী কার্ডে এখানে হয়েছে, কিন্তু আপাতত যদি কোনো সমস্যা হয় তাহলে এখান থেকে কোনো কার্ড দিলে আমি একটু ফেসিলিটি পাবো, এইটা আমার মূল বক্তব্য।
দেখুন স্বাস্থ্যসাথী কার্ড তো সবাই ইলাজ হচ্ছে,
স্বাস্থ্যসাথী কার্ডেই সবকিছু হবে, ওনাকে বলেও দিয়েছি।
বলে দিয়েছি।
আর আপনার রেজাল্ট বাবু, আপনার যে একটা লাং খারাপ আছে, ওটা এটাই অপারেশন দিয়ে আরাম অত পাওয়া যাবে না, বিকজ আপনার হার্টে প্রবলেম নতুন হয়েছিল, যেখান থেকে আপনি অজ্ঞান হয়ে যাচ্ছিলেন, তো হার্টে কম থেকে শ্বাসকষ্ট বেশি হতো, ওটা ঠিক হবে, কিন্তু লাংসের প্রবলেম হার্ট থেকে ঠিক হয় না। তো একটু একটু শ্বাসকষ্ট আপনার থাকবে, লেকিন আপনাকে হাঁটাচলা করতে হবে, নর্মাল লাইফ লিড করতে হবে, ঠিক আছে? তুমি কিছু বলতে চাও তো বলুন।
আমি গলায় যে হাতে গলায় যেন সর্দিটা জাম হয়ে গেছে,
ওটা ওটা
অনেক মানুষের কাশি।
ওটা আলাদা, ওটা আলাদা। নর্মাল যদি ভাইরাল ফিভার হয়, ভাইরাল ইনফেকশন হয়, এরকম হয়, ও 2-4 দিন মধ্যে ঠিক হয়ে যায়। Any questions from from our media people?
এই যে ট্রিটমেন্টটা হয়েছে, যে সিএসপি অন অ্যাকুয়ার ডেক্সট্রোকার্ডিয়া, এর খরচ কত?
জিরো, পেশেন্টের 0 টাকা দিতে হবে, খালি ওটা ব্লাড টেস্টের টাকা দিতে হয়েছিল, ওটাই খালি কিছু টেস্ট টাকা দিতে হয়েছিল, নো প্রসিজার কস্ট।
আর একটা কোশ্চেন, এর সাকসেস রেট কতটা?
সাকসেস এটা ডিপেন্ড করে কে করছে, কোথা করছে। এই যদি অপারেশন আমাকে করতে হতো বারাসাতে, আমি করতে পারতাম, আমার টিম থাকবে না, তবে একা কিভাবে করবো? উই নিড এ টিম ইনস্টিটিউশন সো দ্যাট আই ক্যান পারফর্ম। সো এন্ড ডেফিনেটলি আমি বলবো এই প্রসিডিওর, বিকজ উই টুক আ রিস্ক, এটা রিস্ক ছিল। এটা যদি আমরা যদি না করতে পারতাম তবে নর্মাল পেসমেকার বসে আসতাম, 20% চান্স হতো হার্ট ডিসফাংশন, তারপরে এই কম্প্রোমাইজ লাংস পেশেন্টে যদি আপনি নর্মাল পেসমেকার বসিয়ে আগে হার্ট ডিসফাংশন করে দেন, এটা খুব বাজে হতো। সো দ্যাট প্রপার that instigate us to do more and more kind of take the challenge কি আমরা সিএসপি করি।
যেমন ভাবে পেশেন্ট জানাচ্ছিলেন যে উনি সব জায়গায় ঘুরেছেন কিন্তু ডায়াগনোসিসই হয়নি।
না না না, এনার হার্টের প্রবলেম নতুন হয়েছিল, লাংস প্রবলেম থেকে ঘুরে অনেক দিন ঘুরেছে, লাংসের জন্য ঘুরেছে। এখন হার্ট ফাংশন ভালো করে করবে, if the heart functions well, it will give some more relief to him, but that shortness of breath will never be totally out. Okay.
Sir, since it's a very rare case, করার আগে আপনাদের as doctors mental preparation কি থাকে?
ওটাই তো বললাম কি we sat for 15 minutes and we felt like আমরা কোনো যুদ্ধে যাচ্ছি। we plan, যেরকম আপনি সিনেমায় দেখেন না কি কারগিল বারে যাচ্ছে লোক, তো কত প্ল্যানিং করছে, এটা করছে, তো we just planned well, Arnav can come, Arnav, and we all sat and we decided, Somnath please, Dr. Somnath, I couldn't see Dr. Somnath, cardiac anesthetic, so we all discuss 15 minutes যে আমরা কি কি হয় যাব, কি করব, আর যদি অসুবিধা হয় তো ডক্টর সোমনাথ কিভাবে ম্যানেজ করবেন, সব এই সব নিয়ে আমরা 15, লেকিন খুবই it was all because of patience and just like a huge planning করা ছিল। So it was very very kind of strange feeling, কিন্তু আমি বলি আপনাকে আমরা অনেকগুলো কমপ্লেক্স প্রসিডিউর করি, we are used to all these kind of feelings, we are used to these kind of feelings কি difficult আছে।
তারপরে মেশিনটা কি মেশিন স্যার এখানে বসানো?
এটা অ্যাবার্ট না মেট্রোলিক
স্যার এই মেশিনটা
যে কোম্পানি শুরু করলো ওই পেসমেকার আপনার মেট্রোলিক
লনজিভিটি কত বছর?
9 to 10 years 10 to 15 years।
স্যার স্বাস্থ্যসাথী কার্ডের ক্ষেত্রে মেডিকার কি আছে,
কি বলছেন?
মেডিকার ফ্যাসিলিটিস কি আছে, মানে স্বাস্থ্যসাথী কার্ড কি এখানে অ্যাপ্লিকেবল?
स्वास्थ्य कार्ड में मध्य we can do angioplasty with pacemakers, all cardiac procedures we can do, কিছু কিছু অ্যাডভান্সড, খুবই অ্যাডভান্সড প্রসিডিউর যেরকম কার্ডিয়াক ট্রান্সপ্লান্টও এখানে স্বাস্থ্যসাথীতে হচ্ছে, হার্ট প্রত্যারোপণ ওটাও স্বাস্থ্যসাথীতে হচ্ছে। তো স্বাস্থ্যসাথী ইজ এ ওয়ান্ডারফুল স্কিম, ফার্স্ট অফ ইটস কাইন্ড ইন দি ওয়ার্ল্ড। হ্যাঁ, ওখান থেকে অনেক অনেক লোক উপকার পেয়েছে।
অনেক সময় পেশেন্ট পার্টিরা এটা
নিশ্চয়ই।
বলে যে কমপ্লেন করে যে অনেক জায়গায় যে নেওয়া হচ্ছে না
না,
স্বাস্থ্য
আমি তো কার্ডিওলজিস্ট, আমি কার্ডিওলজি ডিপার্টমেন্ট জন্য বলতে পারি কি আমরা এরকম দেখি না। অনেক আজকেই বলছিলাম, আজকে আমি হার্ট অ্যাটাক পেশেন্ট এসেছিলেন, ওনাকে ভর্তি করলাম আমরা, ওনার কার্ড লেকিন ভ্যালিড দেখাচ্ছে না। তো দিস কাইন্ড অফ প্রবলেম হ্যাপেন্স, বাট আদারওয়াইজ ইটস এ ওয়ান্ডারফুল স্কিম, সেভ মেনি পেশেন্টস। Any questions, Soma? Okay, last word from
Suma, conclude.
Soma, conclude and then we can have plans.
Go back to Catalan.
আপনাদের সবাইকে অনেক ধন্যবাদ আপনাদের অমূল্য সময় আমাদের দেওয়ার জন্য। আমরা আমাদের আজকের প্রেস কনফারেন্স এখানে শেষ করছি। আমাদের প্রেস কনফারেন্স শেষ হয়ে যাওয়ার পরে আপনারা যদি ইন্ডিভিজুয়ালি ডক্টরদের সাথে কথা বলতে চান তো নিশ্চয়ই কথা বলতে পারেন। রিফ্রেশমেন্টসের জন্য আমরা বাইরে রিকোয়েস্ট করবো আপনাদের আমাদের সাথে জয়েন করার জন্য। থ্যাংক ইউ ওয়ান্স अगेन। হ্যাঁ, কারোর একটা
থাকবেন।
না, আমি থাকবো না।
হাত সামনে দেবেন স্যার। হাসি একবার।